Uh, this is Venezuela, is in the north of the South America. Uh, we explain you near 80% of the population is in the north part of the country, near the coast. We have four regions, the mountains, the Andean area, the central area, the Great Plains, and Selvatic and eastern area of the country. The 60% of the population live here in the central area, 10% in the Andean, and the rest in the jungle and the eastern area of the country. The big hematology centers are in the central area, one in the western, and two uh, uh, two uh, it's not big centers, two hospitals that have hematology service in the eastern and one in the jungle. But maybe if you need a high level attention of medicine, you need to go to the central area or the western area. The population in Venezuela is 30 millions. The life expectancy is female 76 years and male 74 years. Cancer is the second cause of mortality, and cancer have a high cost to government because this is the medical assistant coverage in Venezuela. 30% of the population use private insurance, 10% corporate insurance that include the military, oil company, or the the minister, the education minister have corporate, and 60% of the people use the public health. The social security 15 years ago was separate from pension from medical assistance. The medical assistance was universal, and the social security only cover right now for retirement plans. Who buys cancer drugs in Venezuela? Only two institutions. This is the private and this is the government. This is the public system. Badan is a foundation since 70s that buy the drugs and is a non-profit foundation and sell the drug with non-profit. Badan buys maybe less than 5% of the drugs, and the government buy 95% of the drug. The government created many years ago, 22 years ago, a high-cost drugs program that start not like a high-cost drugs, start with the national program of dialysis and transplantation, and after that, HIV program. Right now, this high-cost program cover cancer drugs and rare disease. This program cover public system and private system. The patient can use the private system of private physician, but the government give the high-cost drugs for this patient. It's the same. It's not difference about public and private. This program is protected by constitutional law. The program, this is the data from last year's, spent 1,752 millions of dollars a year. This program spent 100 $46 million monthly. This represents 58 US dollar per patient per population year. This is right now the 3% of the total national income, because this is the national income estimated for that year. With the fall of the oil prices and decreases and the crisis, 2 years ago, this represents 0.3% of the national income. Talking about chronic lymphocytic leukemia, the median age of this disease is 68 years. The incidence is calculated, is not confident, but we take about the 3 centers that treat CLL is 0.9 to 1.2 per 100,000 people. This is more or less 1 year more or another year less is 300 new patients every year. In 1988, we treated 68% of the patients, but we learn to treat in different manner the patients, and right now we treated only 32% of the patients, because we expect we have most watch and wait program. We have in the last 10 years we study by sequencing of the AGVH. If the patient have a low risk to progression, we observe we have many patients with 100 or 200 lymphocytes in peripheral blood, but don't have symptoms, don't have aggressive progression, and do not treat these patients. Since 1998, FCR is the standard of treatment in Venezuela. And since 2014, Venda rituximab for patients that have 70 years old or high. We have lenalidomide, ofatumumab, alemtuzumab, and chlorambucil. But these 2 treatments are the standards and the more treatment used in Venezuela. The treatment needs about 100 patients every year need to start treatment. These patients are high-risk patients only. And we observe 20% of progression in 1 year, 52% of the patient progress in 2 years, and only 28% have 5 years or more without progression. About the cost in Venezuela of fludarabine, cyclophosphamide, and rituximab, this is the cost. $2,600 by cycle. This is the total for 5 cycles. The patients do not receive 5 cycles. Probably 4 or 5 cycles is the median. This is the cost of only drugs. In 5 years, we spent $1,050,000-$60,000. 28 patients with long progression-free survival cost these dollars only in drugs because new treatments. With the new treatments, we need to demonstrate that the patient cost similar or less than this cost. The only situation is to demonstrate that you have advantage. The oral route is an advantage. Low medical assistance costs, less disease progression, less mortality, or better quality of life. This is the big challenge in Latin America because the top three CLL incidents in Latin America are these three countries that you see here, with a high change in the income, in the national income. This is the data of last year, of 2014, and this is 2015. Probably these three countries have more limitation, more economic limitation in the next years to treat patients with high-cost drugs. So, I resume 7 lessons learning in 25 years of high-cost office, discuss with the administration and with the doctors that works in economy, pharmacoeconomy, is that cannot cover everything, obviously. Need to choose the best treatment for the patients, some treatments for selected patients, because new treatments probably is not for all patients, only for very selected patients. See better overall survival than progression-free survival. Try to off-treatment survival. The government have a plan in CML, for example. The government have a program to stop treatment in a low-risk CML patients. Quality of life and palliative medicine for the patient that is probably not covered with the best treatment. And we need best diagnosis to choose the new drugs that probably we can use a biology surrogate marker or something like the DNA that doctor present. Okay, thank you.
Thank you. That gets us down to real life. I noticed you wrote down lenalidomide again. I saw it twice today. This is surprising. Is that the generic formulation?
No, it's Revlimid.
It's Revlimid, the original. It's not Revlid.
In Venezuela, there are no generic.
Really?
All the drugs are original.
Okay.
Some in the last 1 year, one year and a half, the government introduced some generics from India, but for example, in CML last years, the government approved 2 generics of imatinib.
Yeah.
But in November, the government suspended the generics and returned to Gleevec. I don't know what happened.
Why? You don't know why?
I don't know, but I think there are many problems with reported about side effects, and the National Regulatory Office suspend the license of the generics and return to.
There's some published data, in fact, of imatinib generic. And I also saw Campath, alemtuzumab. So you still managed to get it?
We use the multiple sclerosis formulation.
Really?
Yeah.
But But I mean, the doses is
Yes, we
minute,
use more vials.
but the cost becomes phenomenal, though, because multiple sclerosis, the
Yes,
costs remain high. That they give a
because only for very selective patients. And
very selected. Okay,
yeah.
and that's very
It's not
clear.
for all. Yeah.
It's very clear. Yeah.
One of the questions, because I thought you brought up a good point when you were talking about when you look at these new drugs coming in, is all the different associated costs, because you mentioned just drug costs. But, one of the things we found in the United States when we started looking at is again, you could, with certain chemotherapies in solid tumors, you could reduce hospitalizations for complications of the illness. And actually really, so the cost of the drugs get offset because of decrease. In Venezuela, are you able to kind of capture the the other costs, the hospital costs, the other medical costs, of a cancer patient well, so you can kind of measure that within Venezuela? So,
Well,
in other words, here's the cost of a drug, but the patient came in the hospital for pneumonias,
yeah. We
less.
calculate for CLL about our institution is probably the cost in 5 years duplicate, because the cost only in drugs for one cycle is 2,600.
Yeah.
But with medical assistant complication, infections, thrombocytopenia, the problem with immunosuppression after fludarabine,
Yeah.
and herpes
So,
zoster.
so that's where the other costs were coming in.
We calculate about $5,000
Okay.
for cycle.
And what about for patients who don't get chemotherapy? Because sometimes the illness will bring them in the hospital because of pneumonias and infections and
Yes,
immunosuppression.
and the if we use an oral drug is a very convenience, because we have few centers localized, probably many far from patients, and if you can use a local hematology that can proceed an hematology and examine the patient, but the patient do not to need travel to 200 or 300 kilometers for every week to assistance. This is a cost. This is the cost.
Have the new drugs we've been discussing today reached Venezuela?
No, we don't have probably ibrutinib this year and Gaziba this year, but until now it's not approved